speech perception, particularly in noise, becomes more difficult with age. And we know hearing loss only explains part of the story. So what we have here on the left-hand side is somebody with difficulty hearing in noise. On the right-hand side, we've got successful hearing in noise. Now, we can give somebody hearing aids. This increases the volume, but we still see that there's a gap between people who have difficulties hearing in noise and those who are successful. And one of the explanations for that gap is looking at the role of cognition. And over the last decade, this has emerged as being something which is really important in speech intelligibility and speech perception. So, the role of cognition. There are a number of questions that we still need answering. First of all, what is the nature of the relationship between speech perception and cognition? And what aspects of cognition are important for speech complexity? But to start off with, what do we mean by cognition? So typically, when we're talking about cognition, we think of two main aspects. First of all, attention, which I've got down here is the ability to actively process specific information present in our environment, and working memory. So working memory's had a lot of press lately, and this is the ability to both simultaneously store and process task-relevant information. And we can really think, there's often quite a bit of overlap in terms of attention and working memory. You can see it in the definitions there. So we can think of attention and working memory being two sides of the same coin. But of course, the story is much more complex than that. I'm not a psychologist, but I can give a bit of an overview of some of the really important aspects of cognition. And one of those is executive functions. So to try and give you some sort of indication of what we mean by executive function or executive processing, if you think about if you're having a conversation in a group of people in a noisy environment, to be able to do that, you need to monitor what's being said. Say you're at a dinner table, to monitor what's being said, you need to switch attention to whoever's talking, and you need to constantly update your memory to be able to listen to what's going on. So these are the kind of processes that we're thinking about when we're talking about executive functions. And there are three. So we can see executive functions are like an umbrella for cognition, where we've got working memory, and there are two different aspects here. There's inhibitory control, of which attention is part of that. Part of the inhibition of attention is also important. So it's your ability to be able to ignore the other people around you. I think Matt was talking about that earlier when he was talking about his two speakers when they were having a conversation. And both of these two work together to give cognitive flexibility. So what have we done in terms of our research? Well, the research question that we've asked and we're trying to answer is which aspects of cognition are important for speech perception. And the approach we've taken, rather than carrying out a brand new study, is to take some baseline data that we've already collected from a couple of auditory training studies. So the two studies, two auditory training studies that we've done. The one on the left was a randomized control trial, which we did in non-hearing aid users with people with mild hearing loss. And the second study was a repeated measures study using existing hearing aid users. So I'm going to go and talk today about auditory training study number 1. If you miss what I say or you want to read more about it, we recently published a paper in Frontiers in Psychology looking at this whole aspect of the relationship between speech and cognition. This is freely available, it's open access, so you'll be able to go and get this if you just look on Google Scholar. So in terms of the speech tests that we use in the study, we use 3 different speech tests, and they're shown here in increasing speech test complexity. We've got a phoneme discrimination task, so this would be, for example, identifying 2 phonemes, and the threshold is, for example, on here we've got A and E. They'll move closer and closer and sound more and more similar, and the point where you can just discriminate that there are 2 phonemes is your threshold. There's the digit triplet word in noise test. So this is the test that Action on Hearing Loss use in their Hear Check screening task, and that's a word, so it's numbers from 1 to 10. And then finally, we've got our most complex speech test, which is a sentence in noise test. I've got some slides here, which I won't go into, but basically this is to just show that there's a broad range of responses across our sample of mild hearing aid users. And it just goes to show, as we've seen before, that you can have a big range of speech intelligibility measures, even though people have just got a relatively small hearing loss. In terms of our cognitive measures, we've got attention here and working memory. We've got simple measures here going to our most complex measures. So in terms of attention, we have a single attention task here where the task is to look at what we call a telephone directory, and the aim is to try and identify pairs of crosses or stars or squares or circles. So this is a simple attention task. A more complex attention task is one of divided attention. Here it's the same task with the telephone directory, but in addition to doing that task as quickly as possible, the person has to count how many tones are being played in the background. So that could vary in series from 2 to 7. In terms of working memory, there's a very simple digit span backwards test where you hear a number of digits and your task is to repeat them in reverse order. And a more complex span test would be something like the visual letter monitoring task where individual letters will appear on a computer screen and your job would be to identify when you saw 3-letter words. So you're having to constantly go back and update your memory. So these are the measures that we're going to be talking about today. And the bottom 2 tests that I've shown here are tests that index executive function. So looking at hearing and cognition and deciding what's important, what we have here are 3 different graphs. We've got hearing threshold on this axis. On this axis, we've got the signal to noise ratio of the words and the sentences. And you can see that for each of the 2 types of word tests and the sentences, there was a significant correlation between hearing sensitivity and the speech and noise test, which we would expect. When we're looking at the relationship with cognition, we found that we only saw a significant relationship with sentences. So here we've got a significant correlation with sentences and the backward digit span test and the sentences with the divided attention tasks. So we saw that attention and working memory correlated with the sentences only. What we wanted to do was to take the analysis a bit further and to take out other confounds such as hearing loss. So we did a regression analysis. We've got the 2 different types of triple digit test here when we're varying the speech and varying the noise, and this is the sentences. In the model, hearing goes first, so we push that into the model so we account for hearing, and then we can see what happens with cognition, and we can see if there's any correlations. We've divided them into working memory tasks, so all the working memory tasks are in one factor, and then the attention tasks are in another. And there's a lot of numbers here, I do apologise, but the key point is shown in blue. So for the 2-digit triplet test, we can see that there's a significant correlation with putone audiometry, with hearing loss. But it's only with the sentences do we see a significant correlation with audiometry as well as attention. So again, we only see an impact of cognition with the sentences. So to summarise this, if we look here, we've got increasing the speech test complexity, our 3 different measures that we used of speech. There was no effect of hearing and cognition with the phoneme discrimination. For the digit triplets in noise, there was an effect of hearing but not of cognition. And for sentence and noise, there was an effect of both hearing and cognition. So our conclusions from this analysis was that contributions to hearing sensitivity and cognition vary according to the complexity of the speech tests. And the relationship between speech performance and cognition is likely to be specific to the tests used. So I think this is really important when you're talking about speech tests or cognition. We need to look at the individual tests, not see them simply as a whole. So what does this mean to you? Well, for clinicians and practitioners, when you're assessing speech intelligibility, it's important that you're aware of what the impact is of the speech measure that you're actually using. In terms of future directions, what we really want to try and do is to understand more about the relationship between speech perception, cognition and self-report. And here we've got like a triangle of the 3 of them all together. We've already shown that there is some correlation between cognition and speech. And I haven't shown you the results, but it's in our paper. There's also some correlations with some measures of self-report. And self-report, I think, is really important when you're trying to go and tap into what it is that the person really has a problem with. We're going to do the same kind of analysis again with our second auditory training study. This time we'll be looking at people who are hearing aid users. with mild to moderate hearing loss. And we've currently got a paper that we'll be submitting in the next couple of weeks. And one of the things that came out of that is that we showed that there was no correlation between cognition and self-report. So really what we want to try and do is to disentangle what's going on and look, instead of doing this sort of exploratory analysis, to have some specific questions that we're trying to address to try and understand what the relationship is between speech, self-report and cognition. So what does this mean to you? So interventions for hearing loss, I don't really need to spend a lot of time on this. Many of you will be familiar with the Boothroyd 2007 paper where he talks about 4 different types of management. I'm sure there's been a lot of discussion today about hearing aids. I'm going to say a little bit more now about perceptual training to improve speech, perception and communication, and a little bit about instruction in the use of technologies and controlling the listening environment. So, listening and cognition with auditory training. So how does auditory training work? Well, traditionally, we can think of auditory training as being a bottom-up process. So often people are looking and considering bottom-up sensory refinement of the speech stimuli. But over the last few years, there's becoming increasing recognition of the top-down control of cognition on our speech perception abilities. And really, when we're thinking about auditory training, the real value of auditory training isn't in the task that's being trained, it's the transfer of that training onto real-world measures. And we can think about this in terms of near versus far transfer. So we have near transfer here, up to far transfer. So a near transfer would be when you're trained on a particular task and the measure that you your outcome measure might be the same task but perhaps with a different speaker. And we can go along the spectrum here to a far transfer measure, which could be an untrained task in a different modality. For example, you might train on a hearing task, but you might measure the task, another task in the visual modality. And what we're really after is looking at real-world benefit, not simply improvement on the trained task. So does it work? What's the evidence? Well, myself and Helen Henshaw did a systematic review of the literature, and we published this in 2013. And basically, of all the literature that we looked at, the message was very clear. People always improve on the task that they train on. What's uncertain is the transfer of learning, and that's really, like I was saying, is what we're interested in. So we've done 3 training studies. The first 2 I've mentioned briefly. The third training study here is a study of working memory, which I'll say a little bit about later on. So looking at the first training study, this is the randomized control trial. This is a summary of the results where we've got measures of communication, cognition, and speech perception. We have our simple measures and our complex measures. What we found was that after the training, there was no improvement on any of these measures which were assessed with our simple outcome measures. So on the Glasgow Hearing Aid Benefit Profile, that was watching TV, a single attention and a simple span test, and a speech in noise task using energetic masking, there was no improvement. But what we did see was that we got significant improvements on our complex tasks. So on the Glasgow Hearing Aid Benefit Profile, that would be having a conversation with a number of people in a group. We saw significant improvements. There were significant improvements on a divided attention task and also a complex working memory test, which was visual letter monitoring. So this led us to conclude that for listening abilities, improvement in complex cognition may be more important than the refinement of the sensory skills per se. So when we were looking at these results, we thought, do you know, these measures here all index executive processes. So this is the attention switching, the memory updating. We didn't see an improvement in a simple and energetic masked speech and noise test. What would happen if we used a speech test that used informational masking? That's where something like a competing speech task where you've got speech against speech. So we did a second training study, and these were the results that we found. So this was a competing speech task, 2 single speakers competing against each other. We used a repeated measures design, And we can see this is the signal-to-noise ratio of the speech task. These are the 3 visits. We can see there was no change between time T1 and time T2, where we had a control period. But after a week of training, when the hearing aid users came back at the 3rd appointment, there was a significant improvement in their competing speech measures. And this was with a moderate effect size, which is quite high for training studies. So it suggests that, again, if you're going to go and be looking at outcome measures to assess auditory training, you really need to be looking at complex measures. In terms of the benefits that participants reported, we did a post-training feedback questionnaire. We asked what was the best thing and the worst thing about the training. And these are things that people offered. It's an open-ended question. There wasn't any prompting. And about a quarter of the people reported that after they did the training, they experienced improved concentration and attention. And a similar number also reported that they became more aware of their hearing difficulties. These are people with mild hearing loss, so some of them weren't too aware of what their difficulties were. We held 2 focus groups, and one of the key themes that came out was that there was an increased awareness of the role of attention and concentration in listening. And these are the kinds of things that people were saying. I've got to pay more attention and focus, I've got to pay attention and focus more than I used to. When you are concentrating, you can hear more. And again, people were reporting improved concentration and listening post-training. So the training made me want to listen to the one person I was facing. You could do that better after the training. And this final one, you've been listening before, you've not been listening before, now you're listening. So people were reporting not just, we weren't just showing sort of improvements in our outcome measures, people were reporting benefits from the training. So our summary and conclusions are that we listen with our brains. Post-training improvements are shown for complex but not simple measures of communication, cognition and speech perception. So for the transfer of learning, complexity counts, and improvements appear to draw upon these executive processes that I was talking about. The benefits of training were evident on the challenging tasks, the tasks that people were really being pushed on. On the simple tasks, we didn't see any improvements. And we conclude that outcomes need to be sensitive to whatever the intended mechanism of benefit was. So with these results, our next question was, if we trained cognition directly, would we find that a better route to patient benefit? So we carried out a working memory, a cognitive training study using the CogMed training package. This was a really high quality study. We did a double-blind randomized control trial where half the people were allocated to the adaptive training. So this is making the training easier or more difficult depending on where their levels were. And there was an active control, which meant that the patients didn't know, or the participants didn't know, whether they were in the experimental group or the control group, because they all had some kind of training stimuli. The difference with the active control was that where the experimental group had adaptive changes to the measures, the active control, the measures were always fixed at 3 different sort of span tasks. So I'm going to go and show you some results just prior to the training and immediately post-training. We did a whole bunch of outcome measures because we wanted to see where the training actually had its impact, if it did at all. So going back to our near transfer and our far transfer, these range from digit span. So the training was primarily a span task, going all the way through to a competing speech outcome measure with various self-report question as along the way. So in terms of the on-task improvement on the measures that people were actually training on, these are all our participants who took part, and everybody showed some improvement. They're ranked here in order of improvement. So in answer to our question, does the performance improved on the trained CogMed task? The answer was yes. When we were looking at improvements in working memory, here we're looking at an auditory backward digit span test. So it was the same as the trained stimuli, but was with an untrained talker. So we had a test that was near transfer. We've got our trained group, our control group. Anything above the line shows an improvement. We can see that in this backward digit span test, there was a significant improvement where there was no change in the control group. In terms of the analysis, there was no main effect, but there was an interaction between the group and the visit, which suggested that there was some significant effective training. So in answer to our question, does visual working memory training result in improvements for trained tasks in the auditory domain? The answer was yes. I'm going to skip this slide and go straight to the competing speech task. So remember, this is the FAR transfer task. It's the measure that we kind of took was most representative of real-world benefit. And here we saw no change in either of the groups. So in answer to our question, does working memory training result in improvements on a cognitively demanding speech task? The answer was no. So our summary and conclusions were there were improvements seen on the trained tasks, so there was on-task learning, exactly as we've seen with our auditory training tasks. There was some training on a working memory task that was in the auditory domain, so there was some near transfer, but we didn't see any improvements on a cognitively demanding speech perception task, which was more representative of real-world listening. So we conclude from this it's unlikely that training cognition in isolation, which we're doing, we were just training working memory, outside the context of speech perception will actually give any real-world benefits. And what we'd like to do next is to try and make our speech tasks, which are more relevant to people with hearing loss, and include in them sort of measures of executive processing. So one of the measures we could use for training would be a competing speech task. So you're using relevant training stimuli. So we've got a grant application in at the moment. We're hoping to be doing that work next year. So I've got about 5 minutes now just to talk about some highlights from my team and some of my collaborators this year. Just a few things that I think, I'm really excited about and I'd like to tell you about. One is on the telehealth and self-management. Some of you might have heard me talking about this study before where we've used reusable learning objects. And we've developed these interactive multimedia videos. We've now got this package, it's called CETA here, and there are 10 different types of videos or reusable learning objects, looking at a whole range of practical issues as well as psychosocial issues. So we've got issues around expectations, acclimatization, and communication tactics. I'm going to show you a couple of videos now. If we could play the first one, please.
Developing new habits. You will already have experience of adapting to new sounds without giving it much thought. For example, have you ever moved house near to a busy road or railway line, or bought a new phone with a different ringtone? First, we immediately notice each unfamiliar noise, such as a retraining car. Gradually, our brain adapts, and we no longer notice the noise until someone draws our attention to it.
Okay, so that was an example from the acclimatization video. If we could play the next one, which is around hearing aid insertion. Could we play the next video, please?
The inner canal piece of the ear mold, where the sound comes out, should be facing inwards towards the ear. Recognize the shape of the ear mold with the shape of your ear. Hold the back of the ear mold with your finger and thumb. The tubing from the ear mold should be traveling upwards. Keeping the ear mold upright, lift it straight up to your ear without rotating your hand and wrist. Think of a cup of tea. Don't spill it.
Okay, and our final clip, we had a series of testimonials. So this is a clip of a husband and wife having a discussion around the wife's hearing loss. If you could have the final video, please.
Hearing loss it's not visible in any way. I need constant reminders because actually you don't look like you can't hear. You don't behave like you can't hear. And it's my limitation as a bloke, I suppose, is I can't remember that you can't hear without all those constant reminders.
Okay, so you can see we've got a whole range of different media. We've got animations, videos, cartoons, and everything's subtitled. We carried out a randomized controlled trial in 200 hearing aid users, and we used a whole range of outcome measures that I've shown here. And this is just a summary of the results that we found. We found that take-up and adherence was very high. 78% of our clinic sample agreed to take part in the study. Adherence was around about 95%. There was evidence of self-management, so half the people used the RLOs at least 2 or more times, about a fifth used them 3 or more times, so people were going back to the RLOs, to the videos, to find out more about their hearing loss and their hearing aids. There was a significant improvement in knowledge in the group who got the RLOs. There were significant improvement in practical handling skills, so people were better able to manipulate their hearing aids. There was sort of mixed results in terms of hearing aid outcomes, in terms of questionnaires, but we showed that in suboptimal users, that group were using their hearing aids significantly more than the control group. And all of these were showed large clinical effect sizes. The RLOs were valued by the users, and we showed that in around 70% of people, the RLOs in the form of a DVD were cost effective. See to Hear was made available on DVD. We partnered with PC Worth to go and get the RLOs out in DVD format. However, the uptake of this has been pretty low. They weren't very expensive, maybe £1.50, but actually certainly for NHS departments, £1.50 is £1.50 too much. So this is what I'm really excited about. We've now about to put all the RLOs online. We're calling them See to Hear Online. They're being put on YouTube. They can be downloaded on on smartphones and tablets. And you can see here we've got the custom mold videos, the open fit videos, and then we've got hearing aid testimonials. This isn't fully complete, but we're looking to make these freely available. There's going to be an official launch of See to Hear Online at the BAA conference on the 25th of November. The week beforehand, there's going to be a bit of a social media campaign, so you might see these coming through BSHAR, BSA, BAA, and other organisations, because I really, really want to get the word out, because this is something that's free. People can access it. There's going to be no charge for it. It's quite nice because we'll have some analytics so we can see who's using them, where in the UK they're coming from, where in the world people are looking at with these. And what's really nice is the main research paper on the trial was published yesterday. So this coincides very nicely with the launch of See to Hear Online. Our future developments, we're currently developing some RLOs, or some videos for communication partners, so we're specifically focusing on those, and there's going to be much more interactivity in those RLOs. And then I've got a grant application in to try and individualise the RLOs. So instead of a one-size-fits-all that we have at the moment, people will get certain bits which are relevant to them. In terms of patient-centred care, some of you may become more aware that there's much more focus now on looking at theoretically driven health behaviour change. And this is relatively new within audiology. There's a number of health psychology or health behaviour change models. The trans-theoretical model, many of you are more likely to have heard of that. There's the health belief model. Both of those have already been written about in terms of audiology practices. We've got a paper coming out looking at the self-regulatory model, which focuses on psychosocial issues of hearing loss. And I think this model here, the COM-B model, which is due to be published, will be something which really picks up within audiology. We're guest editing a special issue of the International Journal of Audiology, looking specifically at audiology and health psychology, which should be out early next year. And finally, some of you may have seen some of the results from a mild to moderate hearing loss priority partnership setting, which was done with the James Lind Alliance. This involved Barry Downs, who represented BSHAR, And we worked with a whole bunch of other audiology professional groups and charities. And the idea was to try and identify the top 10 research priorities for mild to moderate hearing loss, which were relevant to not researchers like me, but to clinicians and patients. In September, the top 10 priorities were identified. It was a great long process, which I haven't got time to go into. If you're interested, there was a BSA Lightning update, which is on the BSA website. These top 10 priorities are also on our website, and we've got a letter on these due to come out in the Lancet shortly. Finally, this is my personal highlight. We won the Ear and Hearing Editors Award for being the best paper 2017 on the first auditory training study that I spoke about. And this is us getting the award in March. Okay, thank you.